Okay, hello everyone. I'm Karen Scozzina. I'm a pediatrician in the ETSU Department of Pediatrics and director of the Health Institute. As new people join, feel free to introduce yourself. I see we have quite a lot of faculty, staff, and students from ETSU, as well as some folks from outside ETSU, so welcome. I am going to be introducing our speaker today, Dr. Martin Olson. The Child and Family Health Institute was established just this past year with a mission of promoting interprofessional and transdisciplinary research, education, and service around child and family health. Welcome to our January collaborative series meeting for the CFHI. Today's session, as usual, will include time for questions, discussions, and networking. It is being recorded. Feel free to add in questions you may have or comments that if during the presentation. We will make sure that we try to get to all of those questions. And as I said, we'll have time for discussion at the end. I did want to mention that next month, the collaborative series will be held on February 16th via Zoom, and our topics will include overdose awareness, drug use and harm reduction, and naloxone administration. So now to Dr. Olson. He is currently a professor in the ETSU Department of Obstetrics and Gynecology. He joined the faculty of ETSU in 1992. Dr. Olson previously has served both as residency director and department chair. His other accomplishments include holding a patent for a surgical simulator system. He has over 40 peer-reviewed publications, 15 book chapters, and he's been the editor or co-editor of books and scientific presentations in 10 different countries. He's also traveled to the Middle East to help doctors there advocate for health improvement on behalf of female patients. He is the current chair of the Tennessee Perinatal Guidelines Working Group. Since 2016, the ETSU Department of Obstetrics and Gynecology has offered combined prenatal care and medication-assisted therapy in the same physician visit for patients who desire those combined services. Dr. Olson directs the ETSU NAS, or Neonatal Abstinence Syndrome, prevention programs. His current research is in the area of NAS prevention, which is the topic of his presentation and discussion today. So welcome, Dr. Olson.
Well, thank you, Dr. Scozzina, and we're going to start with a brief video on the history of addiction in America.
You know, if you were to follow a busy doctor as he makes his daily round of calls, you'd find yourself having a mighty busy time keeping up with him. Time out for many men of medicine usually means just long enough to enjoy a cigarette. And because they know what a it is to smoke a mild, good-tasting cigarette, they're particular about the brand they choose. In a recent national survey, doctors in all branches of medicine, doctors in all parts of the country were asked, "What cigarette do you smoke, doctor?" Once again, the brand named most was Camel. Yes, according to this repeated nationwide survey, more doctors smoked Camels than any other cigarette. Why not change to Camels for the next 30 days and see what a difference it makes in your smoking enjoyment? See how Camels agree with your throat. See how mild and good tasting a cigarette can be.
We're going to circle back to that video a couple of times in our talk, but first, a tale of two patients. Patient number one, he is a male pilot. He is found to be addicted to buprenorphine, and he's told you can't fly on that stuff. So he goes to his addiction medicine specialist, and the medicine specialist says, we've got two options here. Option one, I'll write a prescription for you. You won't have to worry about relapse. You'll never fly again. Option two, you come off this medication. You have to be motivated to do that. You'll have to accept the risk of relapse. Well, the pod says he's motivated, and that's what he wants to do. He wants to come off this medication. Patient number 2 is pregnant. Well, that means she's a woman, right? She goes to the same addiction medicine specialist. She says, listen, I'm motivated. I don't want my baby to have withdrawal when it's born. I want to come off this stuff. And the standard of care today in America is for that addiction specialist to say, sorry, sweetie, that's too dangerous. So there were a lot of videos I could have selected to emphasize the ties between medicine and addiction. I picked the most sexist one I could find. I admit it, because I think it's time for us to confront an important question. How is it that in 2021 in the United States, a group of men, male pilots, have different therapeutic options than a group of 100% women, pregnant women? We're going to try to talk about that some today. And our topic, of course, is NAS prevention. My credentials are the 29 years in Johnson City that Dr. Skedsina mentioned. The last 4, I've worked preventing NAS, working with over 250 young women, trying to help them confront their addiction. I have no big money financial disclosures. For questions, there's going to be 2 breaks. Use the Zoom comment feature. Miranda is going to text me. Miranda, you want to wave at everybody so they know you exist? And one more housekeeping thing. The term we're going to use is NAS, Neonatal Abstinence Syndrome. There are some researchers out there that want to use NALS, Neonatal Opioid Withdrawal Syndrome. There are other drugs besides opioids that cause this problem. Benzodiazepines cause it. SSRIs cause it. Gabapentin causes it. And in the state of Tennessee, they track NAS. They don't track NALS. So if we're going to use state statistics, we got to use the same disease the state of Tennessee uses. So I'm sticking with NAS. The talk will be broken into 3 areas. We start how we got here. Part 2 is going to talk why it's just time to change management of addiction medicine in America for pregnant women. And finally, how to prevent NAS. So this is the map of NAS in Tennessee. You can see that we are in the worst area, but it's actually even worse than that. You break it down by counties. And there's a lot of research done in Knox County. Let's look at Knox County. That's 10 out of 1,000 babies born have NAS 1%. Washington County is in Northeast. Let's find Northeast Tennessee. Here it is, 4 times as bad as Knoxville. Look at Sullivan County, 5 times as bad as Knoxville. So we're the worst of the worst. So 5%, that's about half of the babies that are opiate exposed newborns. About half of opiate exposed pregnant women will deliver a baby with NAS. So if you got an NAS rate of 5%, that means that 10% of the population is opiate exposed. So think about a 1st grade teacher in Johnson City, Tennessee. She's got 2 or 3 kids in her class that were opiate exposed newborns. It's much worse in our area than most areas of the country. Here is the most important slide in the talk. What causes NAS? Medication-assisted treatment. Look here, 65%. Now these numbers add up to more than 100 because many patients have more than one contributor. That's predominantly Suboxone, Subutex, buprenorphine. Let's look down here. Prescription opioid obtained without a prescription, 27%. Number 1 drug after marijuana seized by the Tennessee Bureau of Investigation, buprenorphine. So over half of this is going to be buprenorphine. So that's the illicit buprenorphine. So now we're talking about probably 80% of NAS in Tennessee and 90% around here is caused by Suboxone. What causes NAS? Suboxone, Suboxone, Suboxone. Pain pills, 5%. Heroin, 6%. Suboxone, Suboxone, Suboxone. And just think about it. How many diseases did this patient walk into the doctor and say, I'm at risk? Me, I'm at risk. Well, 2/3 of the patients that deliver babies with NAS walk into a medication-assisted treatment facility documenting that they are at risk. And this is our drug screens from our local ETSU practice, and you can see it just confirms what you saw. Buprenorphine is right here beside marijuana. Next is benzodiazepine by the same folks that are writing buprenorphine, and pain pills are down here about the same. here is our current standard. And in part 2 of our talk, we're going to talk about why this standard, I believe, is wrong for our area. I would say that the so-called experts from ACOG and the American Society of Addiction Medicine that are writing this are writing from cities where heroin is the big drug or fentanyl. Here are Suboxone, Suboxone, Suboxone. It's a different drug. We can handle it differently than these recommendations. Basically, among the reasons why you should leave patients alone that are on opioids when they're pregnant, multiple things are cited. First, NAS is no big deal. Second, we might provoke a relapse. And third, tapering doesn't work anyways. So those are the reasons we're going to talk about in the part 2. But I'd like to just compare. Buprenorphine is, of course, a medication and an abused substance. And if you compare buprenorphine to alcohol, marijuana, and tobacco, well, ACOG says 0 of those, but buprenorphine is unlimited. However much the patient thinks she might need, that's what you write for. One of the things that addiction medicine specialists will say is that, well, we need to treat addiction like all the other diseases. Well, it turns out I agree with that. Where do we forget about the concept of lowest effective dose of a medication? Buprenorphine is potent. We have this concept called morphine equivalent factors. So what's the drug? If you change it to morphine, how potent is it? So Lortab, for example, 1:1, 1 milligram of Lortab, 1 milligram of morphine. Percocet, 1.5 to 1. Buprenorphine, 30 to 1. The most commonly prescribed dose of buprenorphine in our region appears to be 16 milligrams. That is also the dose that is recommended by the manufacturer. 30 times 16, 480 morphine equivalents. Or as I explained to patients, you're on 48 Lortab 10s a day. Potent stuff. And just a reminder for non-medical folks in the audience, Subutex is buprenorphine alone. Suboxone is buprenorphine plus naloxone. The thinking is that the naloxone makes it less likely the patient will inject the drug or that the patient will take opioids on top of it. It's not as big a factor in preventing that as the manufacturer would have us believe. Diversion is a major problem. Patients snort, smoke, and inject Suboxone and Subutex. I brought my prop here. So patients have described to our residents how they inject Suboxone. They mix it in Mountain Dew and then inject it. These drugs have street names. Box is Suboxone, Tech is Subutex. And as I mentioned, it's the #1 non-cannabis drug seized by the TBI. So let's think about how it got started. How did we get to where we are today with an opioid epidemic? And those of you in hospital situations will remember those little frowny faces and smiley faces that you see when you ask a patient how they're feeling. That goes back to the 90s when the American Pain Society decided that no patient should have pain. They need enough medication to make sure that they don't have pain. And the Joint Commission agreed with that, and they started citing hospitals if the doctors didn't provide enough pain medicine. So, doctors were told, you're a bad doctor, your patient hurts. So the doctors wrote for more medication. Well, it just turns out the American Pain Society was receiving large amounts of funding from Purdue Pharmacy and other opioid manufacturers. And the American Pain Society is now defunct. It went out of business because it could no longer defend all the lawsuits for starting the opioid epidemic. But actually, the story goes back before that. We're back to Dr. Camel here. Ads like this were in the Journal of the American Medical Association, JAMA. In the 40s and 50s, when this campaign was in full force, the American Medical Association was making more money from ads than it was from dues from members. The editor of the Journal of the American Medical Association eventually left that position and went on to get a job for the tobacco industry. So this picture tells me two things. Number one, organized medicine has been making money from addiction for 70 years. But number two, think about life from the view of a patient. So she gets injured. She's put on narcotics to treat her injury. She gets addicted. After a while, her doctor says, you're an addict. I'm not taking care of you anymore. So she goes to the ER. They say, you're an addict. Get out of my ER. So she goes to one of our local clinics, and we have some good clinics here, but we have some clinics that, in my opinion, are financially based. They charge $100 a week, And the answer is that'll be $100 a week. And let me write for 16 milligrams of buprenorphine. If you don't need all that, don't worry about it. You can sell one and take one so that you can come and afford to see me next week. So think about that view of medicine from a patient and recognize that that's how some of us doctors look to a patient. They think that's how we are. And when we start helping them with their addictions, we have a lot of credibility to regain because this is how they look to a patient. It takes me weeks sometimes to get back on a therapeutic level with a patient because she's been treated so bad in the healthcare system. That was my questions time. Let me check here. We're now on question break number 1. Let's see if Miranda sent me anything. Not yet, but this shows I really mean it. You can send questions to Miranda and she will text them to me. All right. Now back to that standard of care in the United States as it is today. And we're going to talk about the reasons that I think that does not apply to our area. NAS, easily treated. That's what it says in the standard. So why will we worry about it when it's easily treated? Well, I'm going to disagree. The death rate is low, but these babies are in the newborn intensive care unit, so some die. It's well under 1%. It is not 0. This is the lowest number I could find. So many numbers are higher, but $35,000 a pop for an NAS admission. And then long-term school performance issues. So here we've got a study. This shows that MRIs on NAS babies are different than MRIs on normal children. Here, their heads are smaller. Tennessee children, this study was done on educational disabilities. Goes into high school. 1992, we've known about this for a long time. So I would say NAS is easily treated as long as you don't mind killing a few patients, spending lots of money, and having permanent brain damage. So that's ridiculous. Now this is even more, that standard was written in 2017. This is from 2019. This is sort of an article that points out that we're doing the right thing according to these authors. Keep doing what we're doing. And I just got on my scissors and cut it out so no one would think that I was misquoting. Studies that have demonstrated developmental outcomes have demonstrated minimal to no long-term neurodevelopmental impact. That's what the American College of OB/GYN, that's what the American Society of Addiction Medicine says. And if you would go talk to a first grade teacher in Johnson City, she would be appalled. I've talked to them. They are appalled to think that experts actually say this. And let's just think about who's not up here. So I would argue that, I'm sure none of you can go call the chair of the American Academy of Pediatrics and say, straighten up. But it is time for national pediatric leaders to step up. Y'all are letting my specialty hand you thousands of damaged babies a year. As an aside, I do have a lecture coming up to the virtual ACOG meeting. So anything I can do to help some of you work with your national pediatric leaders. It's 10% of the babies in our region. It's 2 or 3 kids out of every first grade class. We can't just keep doing what we're doing. Next thing that the so-called experts say about treating pregnant women is that relapses, you can't do what you're doing, Dr. Olson. The patients might relapse. And I use the same terms they use. It's an expected and treatable condition. But look at life again from the view of a patient. She has 2 options. She can stay on buprenorphine the rest of her life, or she can come off someday and accept the risk of relapse. That's how it is. She's 25 years old. If she decides to stay on the rest of her life, her physician fees at $100 a week are $300,000. That's just her doctor's fees. But there's also damage to her family. So this is a study, 2019, and opioid prescriptions include Suboxone and Subutex. So the children of these patients have a higher suicide rate. So the principle of justice would say you don't help one group of patients and harm another one. So by keeping people on buprenorphine the rest of their life, we are harming their children, according to this study. So I've talked to the medical students about what they're learning. Many of them say they are being taught an addict needs to stay on buprenorphine the rest of their life. And of course, we're going back to Dr. Campbell there. My thinking is that leaders have allowed the pharmaceutical industry to influence them because it's a multi-billion-dollar industry, and we need to take care of patients and accept the fact that not everybody wants to work with us. Here is the one study on relapse and pregnancy. And in this study, it was traditional MAT. They were not tapering. They were just following their patients with traditional medication-assisted therapy. 20% withdrew from medical care, 45% relapsed. 65% had a negative outcome of some type. The argument is keep doing what you're doing. And to me, this is an argument to let's do something different, but keep doing what you're doing is the current standard of care in America. What do we really do in our practice? Well, first, we recognize that relapse is life-threatening if the patient relapses on fentanyl, heroin, something that she might overdose and die. So relapse, overdose, death. That is horrible. That is something we've got to work our hardest to prevent. But what's the number one drug in Johnson City and our surrounding area? Well, it's Suboxone and Subutex. People do not relapse, overdose, die on Suboxone and Subutex. So that means that we can push harder than our colleagues in Nashville can push because we're dealing with Suboxone addiction and they're dealing with heroin addiction. Our heroin addiction is we're seeing it, it's getting worse, but still we can push harder and we can treat patients different based on what drug that they're abusing. And we have to make sure our patients are always comfortable reporting a relapse. And have you relapsed today, or have you relapsed since I saw you last? One of the opening questions every time I see a patient, if she says yes, then the answer is, what did you learn? What did you learn to prevent the next relapse? Relapse is a part of addiction management. Patients are going to relapse. Relapse, overdose, death, horrible. But it takes many relapses, many failures to finally figure out how to stay off. When you think about smokers, it's a rare smoker that puts down the cigarettes and done. Nope, they tend to relapse and finally get it right. So relapse is part of the process of finally getting it right for those who do finally get it right. Now we're now moving on towards, it doesn't work to taper. And there are quite a few studies. Most of them are very, very poor studies where they don't even tell us what the dosages were that they used. There are two pretty good studies. They both conclude it doesn't work, but they give us all the numbers and they tell us exactly what they did and what doses they cut down to. So the two studies are similar. So they cut their patients down to 15 milligrams on average. That's 15 milligrams is here. They cut their patients down to 45 Lortab 10s. Their standard deviation was 6 milligrams. So you see, you're going to learn a little bit that the highest dose we write for in our clinic is 8 milligrams. So 85% of their study was done above the level of the highest dose we have right for. We try to get people down to 2 milligrams. 98% of the study was done at a higher dose than our target dose. So for an argument made that what you're doing doesn't work, I would say it hadn't been studied. Our study is ongoing. COVID didn't help matters any in getting it done, but we're working hard to try to show that getting people down to 2 milligrams also it is better than the higher doses usually written. So I'm advocating that rather than saying don't taper, we should be trying to figure out what is the balance. How do we protect babies' brains and also at the same time prevent relapse, overdose, death? Maternal safety versus babies' brains. That's what we should be talking about, not taper or not taper. And I'm of the belief that physicians should provide or obstetricians rather should provide medication-assisted therapy. We take care of pregnant diabetics. We take care of pregnant hypertensives. We think we do a better job with those. We can do a better job with this because the patient sees us not as an addiction medicine person, but as a doctor taking care of her and her baby. And so she works a little bit better with us. Here is our tapered off study. You see it just came out late last year. At that time, we had treated approximately 200 patients overall and helping them lower their doses. We did not hurt anybody. You can't take care of 200 patients not having some bad outcomes. There was one fetal demise in a patient with a history of abruption. She'd already stopped her medication-assisted therapy weeks before, then had the abruption, had a history of abruption. It's my determination that was not related to coming off MAT weeks before. We had one maternal death. Patients do not lose their rights to privacy at the time of death. They still have privacy rights. I can tell you that she did not die of overdose. I can tell you she did not die from her pregnancy. I can tell you that the cause of her death, if you were looking at a list of things that cause deaths in young people, it'd be near the top of the list. But that's all I can tell you. It's my judgment. Tapering had nothing to do with her death, though we did not hurt anybody. We got 21 people off of MAT completely. Interestingly, half of them came off on their own. They don't trust doctors to help them come off. They figure they have to do it on their own. And if the patient comes off medication-assisted therapy, the NAS rate is 0. So I mean, at some level, this is not rocket science. At some level, we have to recognize we're successful getting people off completely about 5% of the time. That, to me, the 5% says that shows me it can be done, and now we got to figure out how to do it better. But 0 is achievable. So NAS is preventable. That is what we've shown. So let's see if Miranda's got some more stuff here for me. I think we're still no questions. Well, I'll talk more slowly then, so you have time to think of questions. All right, reasons why patients are interested in our program. So we're not getting specific. What do we do at ETSU that's different than what's done most of the country? There are other programs in Tennessee that are tapering also. Dr. Towers in Knoxville has an excellent program, and he's now retired and passed that on. But reasons that people come. Well, the best reason is they really want to taper their medication, and they really want to come off. They want to do what's best for their babies. But there's other reasons. We talked about the fact that some patients are working in the private for-profit industry, and they're taking some and they're selling some, and they just really don't want to do that anymore. Some patients are getting it off the street, and they're concerned that if this is discovered, they're getting medication illegally, and that their babies might be taken away from them by Department of Human Services. So they'd rather have a prescription, so that way they don't have to worry about their baby getting taken away. Some others, well, they just don't want their baby to go to the newborn intensive care unit, because then the family will know this patient is addicted, and so therefore they'll look bad, and they don't want their family to know. So let's try to get off and protect our baby. And then just family pressure that the family says, you're pregnant now, come on, isn't it time to start doing something? So the challenge that we have as medical providers is that this group of these other 4, we want to get them to move up to this group. And that's where the trust part comes in. And trust, as I mentioned, it can be very difficult for some of these patients. And that's where doing this work in the OB clinic, in my view, is better than a medication-assisted clinic, because the patient senses we're taking care of her, we're taking care of her baby, we're looking at for her whole family. Just as a marker of challenges working with patients, these images are from Dr. Smythe. These were all removed from patients' vaginas as they attempted to subvert the witness drug screen. So you can see in this one, for example, the patient had aluminum foil over the top, poked it with her finger, outruns the urine. It looks as though she's urinating herself. It's somebody else's urine that she stuck up in her vagina. So we're not doing witnessed drug screens. At present, my concern is that it's difficult enough to build rapport with some of these patients. And to me, witness drug screens look sort of adversarial. And I'd like to have the patient believe that we're all here on the same team trying to help. So we're not doing it at present. Most programs do witness drug screens, most of the traditional MAT programs. So if my patient says, what do I have to do? Well, we got to get her off before she delivers. We like to do it at 34 weeks. When we taper patients, they frequently say it takes 3 weeks before they get over the taper and feel kind of normal again. If we got the patient off by 34 weeks, that'll take her to 37. It'll all be out of the baby's bloodstream. We're going to keep getting urinary drug screens every week. And at the time of admission to the hospital, we're going to get another one. And if we do that, the patients appear to be without NAS in their babies. You know, this newborn cord stat negative, I have a question mark. In our study, 4 patients did all this and their cord stats were positive, but none of those 4 babies had NAS. So it's kind of hard to, 4 patients is not enough to say that the cord stat's not helpful, but there's a cohort that maybe just has enough to kick the cord stat up, and maybe that's not enough to cause NAS. So obviously we need to learn more about that group. So we have a form the patient signs when she walks in the door. She's got a desired taper. Tell her she desires to taper. She's got to sign the agreement. If the patient doesn't want to taper, then that's okay. We talk to her. We say we're happy to take care of your obstetrics. If you want to stay with your same provider and stay on that same dose that you're on, that's the standard care of the United States. That's what you want to do. We're still friends. This is a group of patients that says, I want to do something different. So we talk about risks and benefits. We talk about risk of relapse in this agreement that she signs. Then we're going to calculate the morphine equivalents. And most of the patients are on Suboxone, so that makes it easy. And if the patient says, I'm on half a box a day, well, that is street for I'm taking half of an 8 milligram Suboxone pill a day. And we will then select 4 milligrams for her. Patients will lie. They'll lie for, number one, they'd like you to write a higher dose than they're really taking so that they can then go sell some. Or number two, they say they're at a lower dose than they're really on because they want you to like them and work with them, and they're not trusting enough to think that they can tell you the truth. So they tell you something lower, and then they're going to have withdrawal immediately. So that's why I tend to pick, I'm taking sometimes 4, sometimes or taking a half a box, sometimes I take another quarter box. So I'll pick 6 milligrams for her. That seems to be what she's most likely to succeed on. And then the bens, many patients are on benzodiazepines also. I taper off over a month. Addiction medicine specialists will frequently take several months. I feel like if we've got a pregnant woman, we don't have several months. We have to taper off because of risk of seizures. And there's one paper out there that tapers off in just a week or so. So far we've been tapering off in a month or so, and it's been done safely. So we have a whole supporting team now. So we've got nursing. So when we started this back in, my predecessor, Dr. Selman Welch, started this off, and then he passed it on to me in 2017. And for a while, it was just me and Nurse Claudia Holloway. So you wave at everybody, Claudia, because you're wonderful. And Claudia I talk about stress as a paperwork. Well, that's Claudia for the largest part. So for a while, it was Claudia and I against the world. And then we always, though, had the support of the institution. My partners, my chair, my dean were always excited that we were trying to do something different to help these patients. Soon we added case manager Morgan Tipton. If you're here, Morgan, go ahead and wave. For counseling, we now have 3 options. So if the patient's already got a counselor, stick with that one. We have a navigator program called Strongwell that works with us to really help in multiple areas. They help arrange counseling. They sometimes help to arrange transportation. If there's anybody from Strongwell here, I'd ask you to wave too and take credit for your hard work. Dr. Caitlin Lilienthal she's already joined us, but licenses being what licenses are, she has to wait for that final check in the box before she can do some counseling. But if you're here, Caitlin, go ahead and please also wave. We have a lactation consultant. Her name's Gloria. So this is an area of desired improvement, and Gloria is going to help us do that. And Gloria, go ahead and wave. And finally, all of these folks sort of work together to address other needs. So some patients have trouble with transportation. Some people are in a domestic violence situation. Some people are homeless. We have to assess that entire environment and work with that. So I'm really pleased to see that we have gone just in 4 years from let's try this to what I think is one of the best programs in the United States for an addicted pregnant woman. When the patients come in, we check their controlled substance monitoring database. They just get on the computer and you see who else has written prescriptions for them. It's not perfect, but it's right 90% of the time. And that way, if some other doctor's written something since I saw her last, I know that she's violated her agreement, and then we're not going to write for something else also. We get a urine drug screen every time. And one of the tricks that Claudia figured out was that if she's suspicious, and sometimes just routinely, our patients are pregnant. If they bring a non-pregnant patient's urine and try to do a switch, the pregnancy test will be negative. So on occasion, we'll do a pregnancy test on it to document that it's the patient's urine, or at least a pregnant woman's urine. And then we have to talk about those results. If a patient has repetitive positive drug screens for amphetamines, that's usually meth. We'll talk about transferring her to higher level services. The conversations like, we're not making the progress that you wanted to make with your goals. What can we do differently? Can we send you to a higher level? Patients very rarely take us up on that. They have jobs, they have childcare responsibilities. So this is an area of potential improvement for finding some other ways other than inpatient to get those higher level services. So we will taper about once every 4 weeks. And we start with that 8 milligram pill. And again, that's the highest we write for. Patients come in on 16, and some patients are actually taking 16. They don't know they're supposed to sell half. And they're scared. We've tried a little bit of, let's see if 12 works, but the reality is that it's never worked. So patients are just using us as a way station until they find somebody to write the higher dose that they want. And so it's sort of 8 milligrams is it. And then there's other practices in town, and we're happy to work with you obstetrically if you go one of those other practices. 6 milligrams is our next taper. That tends to be an easy taper, and that gives the patient a chance to have some success too. The 6 milligram to 4 milligram or the 4 milligram to 2 milligram tends to be the worst taper for the patient. And my best guess is that's what they needed all along anyways. And at 2 milligrams, if the patient says, this is the best I can do, the answer is good for you. You've done the best you can for your baby. And we stop there. If the patient says, I want to get off, I want to do even better, then we go to 1 milligram, half a milligram, and then off. And there's a cohort of patients that they just can't quite come off completely. There's that psychological component of addiction. And again, if they're doing the best they can, they're doing the best they can. We need to make them feel good. And that doing the best they can part is certainly something that we try to acknowledge. So if a patient comes in on 4 different drugs, and now she's on one medication, buprenorphine, and 6 milligrams is where she's at, and I really think she's doing the best she can, well, then we're going to have to adapt to her and stop there. If a patient is on 2 milligrams and then walks in and says, I've been lying to you, I've been taking 4, and damn it, you're writing for 4 for me, well, you're not doing the best you can. So, there's 14 other groups in Johnson City that will work with you if you're going to try to game the system. So I recognize the physician relationship is powerful, and that patients have difficulty trusting physicians many times because of their bad experiences. And I emphasize the obstetrician part of my life. I think they react better to an obstetrician than they do to a medication-assisted therapy provider when they're doing an action to take care of their baby. And there's usually something positive that they're doing. So you just make sure that is accentuated. So again, these patients, beaten is the term that I would use to describe some of them at the time of their first visit. They've alienated family members. They've been treated poorly by the healthcare system. They feel like failures, and now they've got an unexpected pregnancy, and they're getting screamed at by family members for your baby's going to have drug withdrawal, and they need to be picked up again. So we're going to make the assumption she wants a healthy baby, and we're going to leave from there. Some people try to game us. You saw the urine things in the body cavities, but most patients, we can get to a point where she's trying to do the best she can. And always make sure the patients come reporting relapse. Again, we're going to prevent relapse, overdose, death. We're going to recognize most patients are going to relapse. And the rule is, you never give a patient a rough time for telling you the truth. So Did you relapse? Yes. What did you learn? That's how we treat it. We use hydroxyzine to help with anxiety and sleep disturbances. Patients will complain of those when they're having withdrawal. Use a clonidine patch. Catapress is the name brand. In Tennessee, you use Catapress. In Virginia, you use clonidine. If you switch them, the insurance company doesn't pay for it. Thorazine is used on occasion to help with cravings. That's our third choice because the risk of tardive dyskinesia. We used to use gabapentin, and that's used in non-pregnant patients, but gabapentin's been shown to have some link to NAS, plus it has a street value. So we've stopped using gabapentin. And then this is fairly new information. This is from 2020. And now cannabis has been shown to make babies' heads smaller. So for the first few years, I figured, well, you're doing the best you can. I'm not going to bother you about your marijuana. If you're getting that buprenorphine down, I'm happy. But looks like that's the wrong thing to do because cannabis also makes babies' heads small. So now we have to work with them also to get their cannabis down. So when patient says she's had a relapse, and obviously what gets our attention, and every clinic, there's some patients that you took a little extra. So to me, taking a little extra is different than I found some heroin, injected it. So we're first confirming the patient is not at risk of relapse, overdose, death. Ask her what she learned, point out that it's common. I use the smoking analogy many times to say, people relapse. Patient number one just says, yeah, I relapsed. And patient number two is guilty, afraid to even talk to me about it. And you have to adapt to where the patient's coming from. We've had patients, especially in domestic violence situations, partner comes home, gets out of jail, whatever, says, I need half your Suboxone. So she complains that she tells us she's relapsed when really she just wants extra to give to her partner. So, the traditional answer to, boy, I've relapsed is, well, here's more drug. Well, that's not our usual answer. And there are cases, we have gone up on rare occasions, and the rule is you only go up once if we've overdone it. So once a pregnancy. And then, this last bullet is this clinic isn't for everybody talk. And if the patient says, this is just not working for me, it's okay. We're still friends. See, we have an escape valve here in Johnson City. We have 14 other clinics that they can go to. So if the patient says, this is not working, I want more drug, the answer is, well, here's your prescription. If that's how you feel, that's okay. One of the other folks will be glad to take care of you. And, patients do take us up on that. And that's their right to do so. And at some level, we have to push hard enough for some folks to succeed. And unfortunately, not everybody succeeds. We have to remember those links to domestic violence and always be suspicious of potential impact of domestic violence on the patient's addiction. So partners will steal their medicine, partners will withhold it, and only let them have their medication if they do what the partner says. It's kind of routine for partners to share their medication. You go this week and get some medication, I'll go next week and get some medication, and that way we only have to pay twice, half as much. But that doesn't work if you're in a program that's trying to promote lowering your dose. So there are couples issues that we have to address sometimes. This is a story I've heard. How did you get addicted? That's when I see a patient for the first time, what's your story is sort of what I say. And I've heard on multiple occasions, well, my partner said, we need the money. So why don't you go to a Suboxone clinic, tell them you're addicted, then write a prescription. And you'll need to take a little bit every now and then so your drug screen's positive. And then they become addicted. So now, on the other hand, you've got some great family members and partners. So they can be excellent sources of support. For those who've come off frequently, there's good family support. It's not universal, though. There are patients with lousy family support that have still been able to come off. But usually, family support is very important. patients who are tapering will get tempted to take a little extra, and they just decide they'll deal with that problem later. So to keep that from happening, sometimes I'll ask a family member to hold their medication. So if they're on half a pill a day, then they will, their partner will give them, here's your half a pill, and then tomorrow, here's your next half a pill. That gives the partner power or the family member power. So it doesn't always work. Sometimes it works great. Sometimes it doesn't work at all. And it does change the relationship because now one partner has power over the other. But sometimes the challenge is that the patient just wears the family member out. You don't love me. You're not giving me that medicine. And so, it works sometimes. It is a tool in the toolbox. It's not one that works for some people. And then if the family member's in the room, the patient, when you say, have you relapsed? Oh, no. Well, she might be lying to you because she doesn't want the family member to know about it. And you just have to be aware of that too. Some of the stories patients tell me about their history. Frequently, they've started as teenagers, even pre-teenagers. For many of them, other than marijuana, Suboxone is the only drug they ever abused. It's frequently a family member, such as mom, dad's sibling, that started them off on their road to addiction. Their partners are frequently on Suboxone. If the partner's on 16 milligrams a day and the patient's on 4, that makes it hard for the patient to avoid temptation. So we get, lock boxes are good in that situation. Some of these patients have significant mental health issues and they're self-medicating. They can't get into a mental health practice. Suboxone is what's available, so they take that, and that's how they got addicted. It was not really, a mental health issue caused by addiction. It was addiction as a result of untreated mental health issues, and of course the domestic violence. So here's just some patient stories here. These are cut out of a WJHL story on our program from a couple years ago.
I was doing it for a very, very, very long time, and then I found out I was pregnant. I didn't know what would happen with her, but I knew that, there was a chance that she could have some withdrawal. You have very little to go on. Just a little bit of help can go a long way. It made me sick to take that much. It's a very powerful drug. I know if I can do it, anybody can do it. I never thought that we would get here. I really didn't. She's amazing. She's so healthy. She's perfect.
So you can feel the optimism the patients have about themselves and their success, the pride in their success. And in person, it actually feels a little stronger than I clearly remember a woman at 36 weeks gestation skipping out of the office because she was so proud of herself. And the fact that it's the policy in the United States that women are not offered the opportunity to feel proud about themselves for doing what's right for their babies is quite perplexing. And again, these are just unpredictable patients. I don't know how many times I've said, well, this one's going through the motions. Every taper is this clinic isn't for everybody speech, and then walks in the door one day and says, I decided to just come off. So I haven't taken anything since I saw you last. 8 cocaine positives in a row, 9th is negative, 10th is negative, 11th is negative, and somehow, eventually so we get through the patient. So, never give up is the point. It takes some patients months and months to get where they want to get, but as doctors, never give up. So the keys for success in dealing with this group of patients is we, healthcare providers, have to be non-judgmental. We have to promote truthfulness. We're firm but nurturing. So that's the this clinic isn't for everybody talk. You can do what you want, whatever you feel is best. The patient has to own the addiction. And, from 8 milligrams to 2 milligrams, it's time to taper. And if there might be a reason why we're going to put off for a couple of weeks, but the patient knows it's getting to be time to taper. From 2 milligrams on, she owns it. It's her decision. And if she thinks that she's ready, she comes off. And if she thinks she isn't ready, then it's going to have to wait till she is ready. So patient has to own it. We have to recognize the limits of the situation. If the patient is homeless and in a domestic violence situation and our ability to progress is limited, we have to accept that. And finally, though, the goal of the program is NAS reduction. We're not trying to cure people. We're trying to deliver babies. We're trying to pass on healthy babies to our pediatric colleagues. Now, the frustrations we see, I've referred to the regulatory burden. There's forms after forms after forms to fill out. The different pharmacies will have different rules, and I get where they're coming from. A pharmacist told me a story. This pharmacist is working, a man walks in with 3 prescriptions for Suboxone. And these are women. These aren't you. I'm not going to fill that. And the answer is, oh, they're all my baby mamas. When pharmacists see things like that, they say, I don't want to be part of diverting Suboxone. So they make their own little rules. And then there's changing rules by insurance companies. You know, all of a sudden the patient needs a new prior authorization. She's been on this for 4 months now, but time for a new PA. Well, the patient can't get her medicine because of one of these rules. So now she relapses. And that just, to me, is incredibly frustrating when the healthcare system, once again, lets these patients down. And then the incarcerated patients are very challenging at times. For example, a patient I'm seeing, and she's incarcerated for 3 months. So she was 12 weeks and now she's 3 months later. And then she's let out on Wednesday, and I don't see her till Monday, at which time she had been off while in jail, but now she's relapsed and back on again. So, you know, a group of patients, you know, that's a patient we might have been able to put on the off list had we been able to see her the same day she got out. Shout out to PEDS here. So Morgan Tipton works with both OB and PEDS. The Families Free organization has a pop-up party twice a week downstairs. If anybody's here from that bunch, you know, wave at us. Dr. Skatzina has some grants. She's actually got it now. I updated mine up before and at least one of those, she is nice enough to mention the OB department, and Dr. Shaw's doing a comparison study. So we appreciate the collegial work together. So conclusions. Number 1, we need to change the standard of management for opioid addiction in pregnant women in America. NAS has lifelong consequences. The concept as an easily treatable disease should be thrown out the window. All you need is a tape measure. Measure their heads. NAS is preventable. And conclusions 2, we need to recognize the decades-long contribution of organized medicine to the expansion of addiction in our country. So to me, it's not like, should I think about what these folks are saying? No, it's my obligation. This is a multi-billion-dollar business, this industry of addiction management. Well, I better be skeptical in a multi-million-dollar business that involves my patients, in my opinion. I think ETSU can be very proud of the steps we're taking to fight NAS. And I did want to take this time to thank my colleagues, my partners, Dr. Block, Dr. Canavan, the residents and the students are all enthused about working with these patients. So it's a good environment for me. And I think, like I said, I think we can be proud of the fact that we're doing as good for our patients and better than most in the United States. References and a final thought, speaking about the risk of relapse, the fact that some women will fail must not be used as leverage to prevent other women from succeeding. So let's see if I got any questions here. All right. Is naltrexone okay in pregnancy? The thing about naltrexone is if you give it as a shot and the patient ends up having a C-section, then the narcotics for pain relief might not work. So naltrexone is okay in pregnancy. Most patients have not accepted the recommendation that we give them to use it. They seem to want to be off and stay off. If we have a patient on naltrexone during pregnancy, our tendency is to keep her on that medication until around 32, 34 weeks. And then we put her on oral naltrexone so that if she ends up with a C-section, she can still get pain relief from her narcotics. But yes, it's okay. Do you use Subutex or Suboxone? So the standard of care in the United States is to use Subutex. The logic being that Subutex is just got one drug and Suboxone has 2. Of course, you're seeing I'm not following the directions here, so we use both. I would prefer to use Suboxone because Subutex has a higher street value, so patients are less likely to divert it. So if the patient comes to us on Subutex, our tendency is to keep them on that because, again, we've got that difficulty in establishing a productive physician-patient relationship. If they come to us on Suboxone or Street, we tend to keep them on Suboxone. Certainly, the first time I wrote for Suboxone in pregnancy, the patient's partner was very, very angry at me for writing for it, which to me meant he was going to divert it, which to me meant I was doing the right thing. So I have had patients saying, I'm going to put you on Suboxone instead of Subutex, so I think you'll be safer. Thank me for it. So I would, the standard of care is Subutex. If anybody's out there taking a test, the reality is Suboxone is probably the better drug. Do you recommend patients go back on MAT after delivery? Well, we leave that up to a patient. So, and again, if a patient's tapered down to 2 milligrams and she says, I don't think this is going to work for me now that the baby's born, well, then let's write for more for you. The goal is babies without NAS. If the patient thinks that she needs to return to medication-assisted therapy at a higher dose, then we're going to work with her. The answer I would want her to walk out the room feeling is that good for you. You did what you could for your baby. Congratulations, you did the best you could. So if the patient needs MAT after she delivers, then that's what we want. There's a cohort of patients we're seeing now for a second pregnancy. We're now following people out to a year. So at first we were doing the traditional 6 weeks or so. And then we saw patients coming back. We had them down to 1 or 2 milligrams. They transition out to one of the providers. They come back to us again on 16. We have to start all over again. So that is a decision the patient makes, and we support whatever decision she makes. We offer her naltrexone. We offer her counseling. I would say it's an area of improvement, helping those people that have come down or come off maintain that dose. So that in terms of future growth of the program, it's something that we need to work on better. And is there a higher rate of relapse after delivery? I don't know if it's higher or lower. There certainly is some relapse. Advice to give clients trying to taper the dosage. I think take your time is how we do it. There's a cohort that just goes and locks themselves in a room for a month, goes away, and they will go away to another environment so they don't have any friends around them and just get it over with. In our program, most people are taking care of other kids or having jobs, and we're taking 5 or 6 months. And you saw the dose 8, 6, 4, 2, 1, half off. Let's see, a question about what's it look like for a patient if she starts off at 16. So the first time we write for it is 8, and then about 6 months later, she's down to 0 with that 8, 6, 4, 2, 1, half off. What did those 21 neonates look like at 2 years of age? So I think the important point of this is that I know how to prevent NAS. I don't know if that does any good to prevent the long-term school issues. And there's no study being done on lower dosage to know. So in terms of future knowledge that we need, what happens to these babies that come off is a very important piece of information. And that would take, perfect study is going to take 20 years because you're going to have to follow these kids through high school. And ETSU is, well, let's be honest, it is not a tier 1, 2, or 3 medical school that gets lots of grant applications. I mean, Dr. Skedzina, Dr. Shaw, kudos to you. I've never been successful in getting major grant applications, and this would be a long-term one that would need to be done. It does need to be done. What does taper doing rapid brain growth due to long-term neurodevelopment? That's a question that's unanswered. But again, we're going to have to do the studies on brain size, measuring. We know that the baby who has NAS has a smaller brain. So one would logically think that taking drug away from a developing brain would be good for that brain, but that hasn't been proven yet. Again, I don't know whether we're preventing long-term school deficiencies. I know we can prevent NAS. And why do you not recommend a woman to stay on low dose 2 milligram long-term to prevent relapse? Well, if that's what she wants, then that's what we're going to support. So it's up to her. And there's a group of patients that holds a baby in their arm and says, oh, I don't want this stuff in my baby's life. There's another group that says, that baby is keeping me up all night. This is hard work. I'm stressed. Now's not the time to taper. We adapt to the patient. If the patient says, this is the best I can do, this is where I want to stay, the baby's out, we're not preventing NAS anymore, the baby's out. It's up to the patient then, and we support the patient's decision. All right, Dr. Sketz, I think I'm out of time now. It's 1 o'clock.
It is 1 o'clock. Thank you so
You might
much,
be on mute.
Dr. Oh, am I on mute? Let's see. Can you hear me now?
I can hear you.
Oh, good. So we are out of time. Thank you so much, Dr. Olson, for presenting that research and providing a lot of great discussion around the societal context and experience that you've had with your program. And I appreciate everybody's questions. I think we've had some good discussion. I did want to mention that if you want to read more about Dr. Olson's research, that it was published in the Southern Medical Journal in November, and you can access the full text of that journal through the ETSU Medical Library. So thank you all again for joining. Just a reminder that next month on February 16th, we will be continuing our discussion on this topic with a focus on overdose awareness, safe medication storage and disposal, as well as naloxone administration. And a couple of our speakers will include Jennifer Irvin and Sherry Barnett with Insight Alliance. Thanks, everyone.
Thank you.